Okay, it's 2:45, so we should get going. My name is Eli Ip, and I'm head of the diabetes program at Harbor UCLA Medical Center. And the topic for this particular work group is oral agents in type 2 diabetes, difficult cases. So the first question, I think, which is reasonable to ask, are there difficult cases on oral agents? Or is this something that when we encounter, it's basically, well, the A1C isn't in control, so let's move on to insulin. And so we'll spend a little bit of time addressing difficult versus not difficult, as I'll point out to you in a moment, and then this is going to be a case-based discussion that I'm going to be dealing with. So, first of all, so are there easy cases in patients who are on oral agents? And the answer is yes. So if you look at if you look at data in DHS, and this is data that is brand new, and Dr. Guterman was showing you the data this morning. I'm not going to show you the actual tables, but just some analyses taken from the same tables that he showed you this morning. So 17% of patients with diabetes can be classified as easy cases on oral agents. That's not a lot, and I'll explain to you what I mean by easy. This is, however, over 5,000 patients with diabetes who are on monotherapy and with an A1C less than 7%. So these are people who are at goal. They are taking one tablet only, because these are oral agents, and they're doing well. So these are the patients we'd like to have all our patients look like. But obviously in DHS at large, what we're talking about is only 17% of all patients. Another over 2,000 patients are also at goal on dual therapy. And their A1C is also less than 7%. So if you take those two together, you've got about 25% of patients in the Department of Health Services that have filled 2 or more prescriptions within the county system. So that's out of a total of somewhere in the region of about 30,000 patients who are filling their prescriptions within DHS, and so we know what medications they're taking, and do have an A1C measurement, and they fall into this easy-to-treat category. The other 75% are either on oral agents or are on insulin as well, and I'm not going to be dealing with insulin in this particular session. Again, looking at the question of do we have easy cases on oral agents, the question is, can we find other easy targets for management? This is an approach which we're trying to look at right now. I'm not going to go into much detail on this, except to say that we're calling it the stop-risk approach, in which what we're actually looking for are to use the kind of data that Dr. Guterman showed you earlier on today, and find those patients who most easily we can get to the targets that we want, and most effectively, and in the simplest and most cost-effective manner. So what can we learn now about, from the PCMH summary of medication usage, what about the overall statistics? I showed you monotherapy and dual therapy in patients who were actually at goal. What about other people who are using oral agents? So if you take the 33,000 patients or so, again, that have had 2 or more refills, 83% of them are using metformin. 48% of these patients are using sulfonylureas, and only 10% use pioglitazone. So there's overlap because not everybody's on monotherapy. But that's the breakdown of the usage of oral agents in DHS. An interesting fact here is that almost 10% of these patients got refills without having an A1C at all. So that means that we're refilling 10% of our patients without actually having an A1C. That's a hole that we need to fill, because it's not clear that we're refilling at an appropriate level of management if we don't know what the A1C is. So, except for this last statistic, this pattern of usage of metformin, sulfonylurea, and pioglitazone is similar to many other prescribing systems in the US, around the world. Pioglitazone is not frequently, or glitazones are not frequently used in Europe, for example. And since metformin is the key first agent, as Dr. Peters mentioned earlier this morning in her survey of management, and as did Dr. Davidson, metformin is going to be the key drug that's going to be used, and most patients are on it. So, is there anything new to be gleaned from the data that we saw? And here is some more information that I think you will find interesting and which I think is useful. So the number of patients on one oral agent only, but is approximately 7,000 patients. Most of these had an A1C of less than 7%, as I pointed out before. That's 67% of patients who are on modern therapy are actually at goal. But if you look at the number of patients who are on one oral agent only, but their A1C is greater than 7%, in other words, not at goal, this is close to 3,000 patients countywide. That's a lot of people where perhaps we can intervene. If you look at the number of patients who are on metformin and sulfonylurea only, quite a few of these are at goal as well, and I'd mentioned that before. So the number that are now at goal at an A1C of 27%, once you're on dual therapy, it appears that you're less successful at getting to goal, and only 27% are actually at goal on dual therapy, and you have a total there of 7,940 total patients that are on two medications, oral medications alone. And those that now are on dual therapy, sulfonylurea and metformin, but with an A1C of greater than 7%, are 5,822. So if you add up the red numbers, patients on mono or dual therapy account for something like 8,500 patients. The number doesn't appear on the slide, but if you look at those that achieve a fairly reasonable A1C, meaning between 7 and 9, that's over 6,000 patients. Why pick out those with an A1C of 7 to 9%? Because this is a target group that potentially could be treated with another oral agent and not yet be put on insulin. Those with A1Cs greater than 9% probably do need insulin, and many of these in the 7 to 9 group may need insulin as well. But again, this is a session in which we're talking about oral agents. And so what I want to point out from all of these numbers is that while we have a not small number of patients who are at goal on either one or two oral agents, that's a total of 25% of all patients at DHS on which we have these numbers. There are a large number of patients, accounting here for 6,291, in whom an additional agent may be all that's needed to bring them down towards a goal of 7%, or even get them to a goal that's less than 7%. So this, in fact, anybody who's an oral agent who's not at goal could be regarded as a difficult case on oral agents. But there are a whole group of individuals here who are probably relatively easy to manage if we add a third agent. And one of the things that we need to consider, in fact, is the use of more pioglitazone, since very few patients are actually on it, in terms of trying to get these patients to goal. The other, particularly, and this particularly applies to patients who are reluctant to go on insulin. The other approach is to introduce, for patients with A1Cs of less than 10%, if you were in the insulin session that immediately preceded this, anybody who has an A1C of between 8 and 10% is also someone in which introducing basal insulin would be a good idea. That's the BEDO approach, basal insulin and bedtime insulin, and daytime orals. So this is a large group. It's 6,000. Here we go. Another 21% of patients who are potentially easy to treat. So not everybody who seems to be failing oral agents within our system is really failing. It could be with another oral agent or simply giving, and many of them will respond to pioglitazone rather well, or giving them a bedtime insulin may get them to goal. That's a pretty big group. And we'd be getting closer to about 50% of patients, perhaps with A1Cs of less than 7%, which would be an important milestone in our particular patient population. Okay, so now let's get on to talking about some patients that are probably typical of the kind of patients that you see on a day-to-day basis with diabetes. So this is a 61-year-old female with type 2 diabetes for 12 years. She's done well on metformin for this period of time with an A1C that's been between 7 and 7.5%. Over the years, the metformin dose has been increased, and now she's on 1 gram twice a day. She has hypertension, hypercholesterolemia, treated with benazepril, hydrochlorothiazide, simvastatin, BMI 33, not unusual, with an albumin-creatinine ratio that's elevated of 165. Her GFR is 47 mLs per minute, meter squared, and that's estimated, and creatinine is about 1.5. A look back at her chart reveals that the patient has shown up for most of her clinic visits and has been getting labs prior to visits. She's not been successful at weight loss or increasing her physical activity. With decreasing renal function, her PCP is concerned about using metformin in this setting, but is reluctant to change because the drug seems to be very effective in this patient. After all, the A1Cs have been hovering in the low 7s. So these are the options. Discontinue metformin, lower the metformin dose, increase the frequency of estimated GFR monitoring, start a sulfonylurea, start Januvia, or start insulin. A lot of possibilities. So let's take a show of hands. Who would discontinue metformin? Okay. Bunch of people would discontinue metformin. How many would lower the metformin dose? A few more. How many would simply increase the frequency of GFR monitoring? And there are a few who will do that, and it seems to be splitting the side of the room. So this side of the room wants to stop or decrease dose of metformin. This side of the room so far wants to increase GFR monitoring. Would anybody start a sulfonylurea? Nobody likes that. Okay. Januvia? Okay. There are some people on this side of the room. No, they're on that. They're more proactive on that side of the room. Januvia is a good possibility should you decide to do that, because it can be used in patients with renal failure. Finally, would anybody start insulin in this patient? Okay, so everybody seems to agree that there are other alternatives besides starting insulin, and with an A1C that's this good, I don't think that's a reasonable option. Okay, so I'm going to hold on giving you a recommendation on this and go on to the next case, and then we'll come back to this. Okay. So this is a 78-year-old male with type 2 diabetes for 2 years. Has controlled hypertension and chronic kidney disease. He's been doing well on metformin, but on 1 gram per day. He's insufficiently well controlled with an A1C of 9.2. PCP is aware that the patient from time to time forgets to take the evening metformin, and so he was given a pill box, which he then used to monitor the pills that he was taking. And there was some improvement in dosing. He seemed to forget to take the PM dose less often, or he was taking it more often. His LDL cholesterol and blood pressure are at goal. His estimated GFR is 65 and albumin creatinine ratio of 35 on lisinopril and a BMI of 31. So the PCP decides it's time to add a sulfonylurea. She therefore goes through a checklist of comorbidities to decide which sulfonylurea to use. The patient is elderly, 78, has mild chronic kidney disease, and has cognitive issues that have reduced his compliance. So which should she start, glipizide or glimepiride? So there really, you're given only 2 possibilities here. So who would start glipizide? Nobody. Who would start glimepiride? Okay, it should be everybody else. So a lot of people that are sitting on the fence. Okay, so let me see if I can coax you into this by asking anybody who chose glimepiride over glipizide, would you be willing to explain your choice? You're worried about hypoglycemia with glipizide, hypoglycemia with glipizide, and not with glimepiride. You're saying less hypoglycemia with glimepiride. Okay. Anybody else want to comment? And why would that be an advantage? Has compliance issues. Okay. Anybody else have a comment to make about why they chose glimepiride? Okay, so what you're hearing with a little more information provided, that you might, if you took the glimepiride in the morning, have less nighttime hypoglycemia, and everybody seems to agree that in somebody who's forgetting their medication doses, that it may be a better idea to take a long-acting sulfonylurea, which glimepiride is. You only need to take it once a day. In some senses, this is a good problem, because most of our problems deal with patients whose A1Cs are 9, 10, 11, 14, and 16. This is a patient whose A1C is in the range that's much closer to where we want it to be, in the region that's closer to 9, and we think we'll be able to get this patient down to a range where hypoglycemia may be an issue. So, and the decision between glipizide and glimepiride in this particular case is not a simple one. Even though most people seem to prefer glimepiride in this case, and for somebody who is forgetful, this is a good idea. Glipizide is often a better choice in an elderly individual, because you can use very small doses, and in somebody who is forgetting to take the medications, they're often forgetting to eat as well. And when you're on a sulfonylurea and not eating, you're going to also be at risk for hypoglycemia. And so further questioning of the patient with regard to food intake is something that you should do as well. And consider the possibility then of using the glipizide at a time of day. So that was a good thought of giving the glimepiride in the morning, and perhaps it wouldn't be acting quite as extensively at night if you gave the glipizide in the morning only and not in the evening and achieved the effect that you wanted. That's another way in which you could avoid hypoglycemia at night, and perhaps more likely to, because the glipizide is not going to carry all the way over. So, in fact, in this particular case, what I'm trying to bring out is the complexity of the situation. There isn't necessarily a right answer. And it depends on you looking at your patient. I've created a setting in which he is both elderly and has some mild renal failure. So you've got a problem with hypoglycemia potentially, and you've got a problem with compliance. Our patients don't come with one problem at a time. That would be nice if they did. They often come with complex problems, and deciding between two agents, when you have to weigh the relative risk of hypoglycemia or hyperglycemia if the patient misses medications, is something that you need to do often in these situations, and you need a checklist. You need to be looking at what the pros and cons are, and an easy way to do this in a very busy practice is perhaps to think through a checklist for yourself and have it available so that you don't have to start thinking through it again when each patient comes in with this kind of a problem, and this is not an uncommon problem. So I don't think there is a right answer. I think what I might do here is start with a very low dose of glipizide, given the age, once a day only, and see what happens. If it turns out that it's not sufficient and it's not maintaining the patient's glucose through to the next day, then you have the option of either giving a small dose of glipizide in the evening as well, or putting the patient onto glimepiride. Starting on the one doesn't necessarily exclude the possibility that you might decide it's not really working, and glimepiride in the end may be what works best for this particular patient. So let's go back to patient number one. And for this one, I'm going to ask you to do, because this is an opportunity for us to take a look at a handout that was given to you. There's a question, and I'm going to take your question in a second. But what I want, while I'm answering this question, what I would like everybody to do is take out this handout which says oral anti-diabetic medication initiation and adjustment in adults. And the question?
For that last patient,
Yeah.
aside from the sulfonylurea, why not max out the metformin?
Patient was on maximum metformin. Yeah.
Oh, I thought it said 1 gram per day.
It should have been twice a day? Oh, okay. You're absolutely right. It should have been twice a day. Otherwise, the problem is, yes, resolved by that. Yeah. It should have been BID. So that actually would have been a good answer. Yes. Okay. Okay. So now I want you to take a look at this oral medication initiation and adjustments. And the idea of this draft, I think it's a close to finished draft, or maybe the final one, which was developed by the endocrinology group, work group, to be used in the PCMH. And you can see that there are 4 steps. The first is starting with metformin. The second is adding sulfonylurea. The third is adding pioglitazone, or going to number 4, which is adding some insulin. I'm not going to go through this in detail because there are a lot of little details that you really need to read in order to see how this works. And the idea is that this is a protocol that could be used in the PCMH, where eventually, if protocolized, would not need necessarily a provider to make every decision that's involved in this process. And that should make, for those of you who are providers, your life easier, and for those of you who are part of the PCMH to work with an organized protocol, life easier as well, as for the patients who don't have to wait extensive period of time for small adjustments to be made in oral agents. The part that I'd like you to focus on is in part one. There are 1, 2, 3, 4, 5 columns, and I want you to look at the column on the right, which gives you some indications of what to do when you have a falling GFR. So what it says is maximum dose is 1,000 milligrams BID of metformin, and check glomerular filtration rate. Typically, if you have a normal GFR, it's once a year, and adjust dose as necessary. So this is the adjustment that would take place. If you have a GFR that's less than 60, as was the case in this particular patient, you do want to do more monitoring. But the rules have now relaxed for using metformin in patients with chronic kidney disease. And this is really the point to make about this particular patient, and as it appears in this handout as well. It's okay to use metformin today up to an estimated GFR of 30. Once the eGFR gets down to 45, you should be using half of the maximal dose. So that would be only 1 gram a day if you're between 30 and 45, but you should also be checking the eGFRs much more frequently at 3 monthly intervals. Between 45 and 60, you can continue to give metformin at the same dose, but you then should be checking the eGFR at least at 6 monthly intervals. So the approach in this particular patient, based on this handout, would be to increase the frequency of eGFR monitoring, not necessary to stop the metformin, and not necessary to even to lower the metformin dose yet. If the eGFR continues to fall, you've got to watch it carefully, and you may want to decrease the metformin at that point. Metformin's a really, really good drug, as you all know, and it's a pity to give up on it too early. You might get another year or 2 or 3 in any particular patient as you follow them going forward. Okay. This does not seem to want to move on for some reason. Let's see if that'll work. No. Oh. All right. That's what we've just done. We saw the handouts. Okay. So starting sulfonylurea, we just spoke about. So when to stop a sulfonylurea. So this is a 47-year-old Hispanic male with 10 years of type 2 diabetes, hypertension, obesity, and hyperlipidemia. He's been treated with metformin and sulfonylurea at increasing doses. A1C has progressively risen to 9.5 at the last visit. For the last 1 to 2 years, his PCP has been trying to convince him to start insulin, and he has consistently refused, citing his fear of going blind. The PCP gets him to do retinal screening, finally. He'd been refusing to do that too, which along with his albumin-creatinine ratio is within normal limits. So both of them look really good. The PCP then explains that successful management of his glycemic control for the first 8 years of his disease protected him from diabetic microangiopathy, and that insulin would serve the same purpose. the patient is beginning to get convinced, given the normal retinal findings, to give insulin a try. So the PCP wants to start insulin. He plans to continue the metformin because the patient is obese and likely insulin resistant. Should he stop the sulfonylurea? So it's either yes or no. So who says that the sulfonylurea should be stopped? Okay, bunch here, and a bunch there. Who says that the sulfonylurea should be kept on? Just starting insulin. And who said not? Okay. And so the answer, to make this a little more interesting, is it depends. Okay. And so what does it depend on? And yes, your question was the appropriate question, which is what kind of insulin is going to be started? Okay. So why did you ask whether he was being put on Beto?
Well, if it's just bedtime insulin, then you want something
Okay, so the answer that was given at this table is that if the patient's only getting insulin at night, it's only basal insulin, then the whole purpose of Beto, if that's what was begun, is to provide some basal insulin while the oral agents take care of the postprandial rise in glucose, and that's the only situation in which Beto would work. In settings, sometimes we start Beto mistakenly, thinking it's going to work, but in fact, it doesn't. The oral agents are not doing anything anymore. And so one has to then start giving insulin, prandial insulin, as well as the basal insulin. But in situations where Beto works, we'd be working against ourselves if we stopped the sulfonylurea at that point. We actually, even though it looks like the sulfonylurea isn't working, with an A1C of 9.5, we know very well that you need to keep those oral agents in place. The metformin and the sulfonylurea, at that point, the glipizide or glimepiride that we use, you keep them in place to get the insulin out help get the insulin out with meals, particularly the sulfonylurea, and give Beto. On the other hand, if you've decided that this is a patient who needs to get long-acting and short-acting insulin, whatever combination you decide, whether it's NPH and regular, NPH and Lispro, or glargine and Lispro in basal bolus fashion, at that point there's no reason to keep sulfonylurea on board any longer. So stopping it and not stopping it, the sulfonylurea are both correct, depending on which of the two scenarios you've decided to use for starting the insulin. Keep it on with Beto, stop it if you're giving short-acting insulin as well, because that'll do the trick, and that's good enough for covering the meals. Okay, patient with progressively deteriorating glycemic control. This is something that you get to see often. This is one version of it. So this is a 42-year-old female with a 5-year history of type 2 diabetes, treated with metformin, 1 gram BID, glimepiride 8 milligrams daily, so on maximal dose of both. She also has mild hypertension, treated with lisinopril. She weighs 72 kilos, her BMI is 25, her GFR is 90, LDL is 105, her HDL is 62, triglycerides are 87, A1C is 9.3, and the albumin-creatinine ratio is 19. Her glycemic control has been deteriorating over the last 2 years, requiring increasing doses of metformin and then the glimepiride. PCP was considering what the next step should be in management. The discussion with the patient revealed that she was taking her medications as prescribed, so she was adherent, and was now trying to eat less in order to prevent postprandial increases in blood glucose, because whenever she measured her glucoses after meals from time to time, she found that they were really high. So she was spontaneously herself then cutting back. She volunteered that as a result, she lost about 10 pounds in weight. There's no family history of diabetes. So your options are to add another oral agent, let's say pioglitazone, add a GLP-1 agonist. So exenatide is on formulary, it's restricted, but it is something that we could use, or add insulin. So these are the options, and the question is, what should be the next step in this patient? Ask the patient what she wants. Eventually, you should do that. But first, you want to make a decision yourself. What should be the next step? So let me ask you, does this sound familiar? Is this a situation that you've seen before? Okay. So now I'm going to ask you something that's a little different. What about the scenario might suggest that this patient is a little different to the very, very common scenario of deteriorating glycemic control and increasing metformin and increasing glimepiride over the years? What might look a little different here? So you've never had a patient with these kind of numbers. So, well, how many of you have seen this kind of setting with a BMI that's 25, 26? She's been losing some weight, right? She hasn't been eating much. We like to think we seem to think, I should say, that most of our patients have BMIs of 31 to 40 or more. But there are a group of patients with type 2 diabetes who are not all that obese. Now, so a good question that you might want to ask is, I haven't addressed what ethnicity this female patient is. If she were Asian, for example, a BMI of 25 or 26 is certainly overweight, even though it may not be in somebody who's Caucasian or African American, right? So a normal BMI is thinner in people of Asian origin. So we certainly see that. But there's another point that is very, very important, and that is that her HDL in particular isn't just normal, it's actually a little high, right? So an HDL of 62, 65, 70, this is giving you a bit of a clue. So is the weight loss. How many of your patients with type 2 diabetes manage to restrict their food intake and actually lose some weight? Just because they're seeing high glucoses? Yeah, some of them will, and that's what we're after all the time. But in somebody like this who's already fairly lean, it's another question to ask. And so the next step in this patient, in fact, before you make a decision on adding an oral agent, a GLP-1 agonist, or insulin, or you could in the meantime do that, would actually be to ask yourself, could this be a patient with type 1 diabetes? Now, does that make sense? She's been on oral agents for 5 years. Is that right? 5 years, yeah. Could this be type 1 diabetes? Yeah, some people are saying yes. What do we call this kind of diabetes? LADA, right? Latent autoimmune diabetes of adults. And this is something that I thought was really important for you all to think about in your practices. It's thought that LADA might represent anywhere between 5 and 10% of all patients with diabetes. If that's true, and we don't know what the prevalence is here in the United States, if that's true, then some of your patients that you think are non-compliant, that you think are in terrible control because they are not doing what you're suggesting they should be doing, might in fact have type 1 diabetes. And the clues are the weight loss, The clues are the getting towards normal weight or normal weight and an HDL that's elevated. So the interesting thing is, and it's not well known, is that type 1 diabetes, people with type 1 diabetes can actually have an elevated HDL. It's not just normal. It actually can be elevated. So when you see an elevated HDL and you see this kind of a setting, think about the possibility of type 1. And then what you should be doing is measuring C-peptide and an anti-GAD antibody. All of that should be accessible to you. In the coastal cluster, we can also measure IA2 antibodies, which is another useful antibody to measure. And you can get it done. Any of those turn out to be positive, the C-peptide turns out to be low. This patient does then, by definition, have LADA, latent autoimmune diabetes of adults. It's a form of type 1 diabetes, or is type 1 diabetes. And in that setting, patients should definitely be on insulin, should definitely be on prandial insulin. There's no role for beta in somebody with type 1 diabetes. And somebody like this should then probably be referred to one of the diabetes clinics in your area to be managed in a disease management program or by the diabetes clinic. So not everybody that is type 2 diabetes, that looks like they may have type 2 diabetes just by virtue of age, necessarily has type 2 diabetes, and that's important to keep in mind. There is time for probably one more case, unless you want to bring up some questions, because we need to stop, I think. Or should we stop already? Is it? I think that's it. Paul, is it 3:25? Okay. So if there are any questions, I'm happy to answer any during the switchover break. Thank you for your attention.